Okay, I think we can get started here. So we're in the home stretch. We're at our final session of the day. So I wanted to introduce the moderator for this session, Dr. David Goldenberg, and I really appreciate him taking the lead in moderating this. And he will introduce the faculty. And so stick around at the end. We'll give you a little bit of wrap up with respect to MOC and CME, and we'll get together. So, Dr. Goldenberg, you can have it
over. All right. Can everybody hear me okay?
Yes.
All right. Perfect. All right. So I'm David Goldenberg. I'm a clinical assistant professor here at Stanford. I have an interest in medical education as well as healthcare delivery innovation. I'm joined today by three of my colleagues. We have David Lim-Sui, who's a clinical associate professor and director of the GI Fellowship. He specializes in inflammatory bowel disease. We have Nielsen Francis-Becker, who's a clinical associate professor. She's director of our celiac program. Her other clinical and research interests include allergic GI disorders, including eosinophilic esophagitis and motility disorders. Irene Sunu is a clinical assistant professor who specializes in motility disorders. Her research interest is irritable bowel syndrome, microbiome, and FNT. So with that, we can get started. Okay, so first question. 29-year-old woman is admitted with a body mass index of 17 kilograms per meter squared, severe electrolyte abnormalities. She is found to have hypochloremic metabolic alkalosis. She is admitted for fluid resuscitation, electrolyte monitoring, and enteral nutrition support. Which of the following minerals requires close monitoring? Okay, we go back to the question. All right, so we have a young woman here with a low BMI admitted for fluids and nutritional support. And we have a couple of different labs that we need to monitor closely. We can go back to the next slide. Okay, good. Wow, everybody. Dr. Sonu, did you want to take this one?
Sure. So this patient has an eating disorder and is severely malnourished and is at high risk of refeeding syndrome. And so this is a condition where you can get this stark these stark changes in your electrolytes. And as all of you know, it's phosphorus is one that you're at very high risk of depletion. And this is due to the high rise in glycolysis and ATP production once the patients are being fed. And in addition to being severely at risk of getting hypophosphatemia, you can also get hypokalemia and hypomagnesemia as well. But in terms of the best answer for this question, phosphorus is definitely the best answer. And so when there's patients that are not repleted very frequently, then these patients are at very high risk of serious complications, including pulmonary edema, congestive heart failure, as well as sudden cardiac death.
Okay, great. Let's go on to the next question. All right, 26-year-old Caucasian male presents with fever, sore throat for 5 days, along with erythematous non-pruritic rash involving the extremities and arthralgias. Subsequently develops right lower quadrant pain aggravated with meals associated with watery diarrhea. Labs show a white count of 14,900, CRP is elevated to 12, MR enterography shows 20 centimeters of thickened ileum. Upper endoscopy shows multiple erosions in the duodenum and antrum, while colonoscopy shows erythema and inflammation in the terminal ileum and the cecum. Biopsies from both areas demonstrate evidence of leukocytoclastic vasculitis. Skin biopsy also shows leukocytoclastic vasculitis. All right, and they're looking for treatment. So we have sulfasalazine, prednisone, azathioprine, infliximab, or vedolizumab. Should we go back to the question? So just as, okay, so key things here, young man, fever, sore throat, a rash in the extremities, joint pain, white counts, there's elevated inflammatory markers. We have some inflammation in the ileum on MR enterography, and we have inflammation on biopsy as well. And there's a leukocytoclastic vasculitis in the skin as well as in the endoscopic biopsies. So let's look at the answers. Okay. Prednisone, good. Okay, so that's correct here. So this is a case of Henoch-Schönlein purpura, which is a self-limited, someone's changing. Oh, where are we going? Okay. So it's a self-limited systemic small vessel vasculitis. So just as far as vasculitis for the GI boards, there's a couple different questions we're going to be looking at, small and medium. And I always think with the vasculitis, it's important to understand which vessels are being affected because that's going to tell you the type of presentation. So in this case, we have a small vessel vasculitis. So we're going to expect renal involvement. We can expect the rashes, the palpable purpura, and abdominal pain is a key part of this. Most cases are self-limiting, although oral steroids are helpful in patients with abdominal pain. So we typically don't need to have these other maintenance therapies here. You can usually get away with prednisone and then symptoms will improve. Although there are immunosuppressive options for patients that don't respond completely to steroids. Okay, we go to the next slide. So yes, vasculitis, small vessels, usually children, sometimes adults. There's a classic triad. So this is how they'll usually present on the boards with arthritis, hematuria, and palpable purpura.
David, can I interrupt for 1 second? I'm sorry about that. Do you want to have David Limsui do this one as well, since this is part of his slide deck? I'm sorry.
Oh, sure, of course.
There. Sorry about this.
Yeah, no problem. Dr. Limsui, you ready?
Well, no worries. I have nothing much more to what Dr. Goldenberg already summarized so nicely. The findings of the leukocytoclastic vasculitis is pretty pathognomonic, and it's important to think of the classical presentation, of arthritis, hematuria, palpable purpura, and then the GI involvement. And yeah, as he indicated, the correct answer, which the majority of the audience answered correctly, is prednisone initially. Sometimes it can be very self-limited and may not need treatment and supportive care only, but the other answers were more suggestive of more long-term type maintenance therapy, which are rarely needed.
Okay, let's go to the next slide. All right. So which of the following patients is most appropriate candidate for TTG-IgA testing for celiac disease? So we have 4 options here: 18-month-old child whose mother recently confirmed with celiac disease, 33-year-old female patient with CVID whose brother was recently diagnosed with celiac disease, 24-year-old man with unexplained iron deficiency on a strict low FODMAP diet, and lastly, a 26-year-old patient with elevated AST and ALT who maintains a diet with no restrictions. Okay, we'll give a couple seconds here for people to think about things. All right, and we go to the next slide. Good, so we have a split here between B and D, and D is the correct answer. And the reason why B is not correct is in patients with CVID, they're unlikely to mount an IgA response. So this is looking for a TTG IgA testing. So that's that's not going, you get a false normal. We can go through the rest of the questions here. So an 18-month-old child, the TTG test is not indicated for patients who are under 2 years of age. And looking at C, in patients on a strict low FODMAP diet, they will likely have a false normal because of an inadequate gluten ingestion in the diet. So that leaves D here. And we do see elevated AST and ALT in patients with celiac disease. So that should also be considered in the workup for mild transaminitis. We go to the next slide and talk about the clinical presentation. So most patients with celiac disease, the most common presentation is diarrhea, but really if you add up all the other things, atypical presentation is the most common. So be on the lookout for different presentations to mimic for celiac disease. Next slide. Okay, 52-year-old man with a past medical history of hypothyroidism presents with 2 months of watery diarrhea and weight loss. In addition, he notes that his knees have been hurting more significantly and he's having more regular headaches. He has upper endoscopy and duodenal biopsy, which reveal villus atrophy in PAS positive macrophages. Which of the following is the most appropriate treatment for this patient? So we can go back to the question stem. So we're looking for a treatment patient that has chronic diarrhea, weight loss, and biopsies which show villus atrophy with PAS positive macrophages. Classic board buzzword. Okay, should we go to the answers? Good. So most people got this one correct. Ceftriaxone followed by Bactrim. So this patient has Whipple's disease, a multisystemic infection with the Trophorema whipplei species. So this is not very common in clinical practice, although we did have a case of patients will usually present with this weight loss, abdominal pain, neurologic symptoms, as well as the joint pains and the arthralgia is classic. The diagnosis is made on biopsy with the PAS positive foamy macrophages. We can go to the next slide. So patients will have atrophied villi, which explains the malabsorption and the diarrhea. Lymphatic dilation also explains the malabsorption, particularly of the fat. It's important to distinguish from MAC because this is not the only thing with foamy macrophages, but Whipple's does not have acid-fast staining. And this can be confirmed with PCR, and CSF PCR is also important to check for CNS involvement. And treatment is done with induction and, you have the next slide. Treatment is done with induction in the hospital, often with ceftriaxone, and then switch to Bactrim for long-term therapy. Okay, next slide. In which of the following clinical scenarios is human leukocyte antigen DQ2, DQ8 genotype testing recommended to effectively rule out celiac disease? All right. So A, patients with MARS3 lesions with a negative IgA TTG. Evaluation of patients on a gluten-free diet for more than 2 months in whom no testing for celiac disease was done before gluten-free diet. Patients with dermatitis herpetiformis. Patients with suspicion of refractory celiac disease, and patients with previously confirmed celiac disease, and lastly, patients with Turner syndrome. So who would you test the DQ2, DQ8 genotype? Okay, I think we're ready. Good, so 100%. All right, so I think I don't even need to say anything. But I will. So I'll go through these other options here. So in patients that have MARS3 lesions with negative IgA anti-TTG, if you have a negative IgA, you could still send a IgG serology test. Patients with dermatitis herpetiformis, you just need to test them for celiac disease. So patients with Turner syndrome here, they're trying to get at the fact that celiac disease can be associated with Down syndrome. So patients with Down syndrome have celiac disease, have about a 10% prevalence of celiac disease. And looking for refractory celiac disease, that's you would just test them for TTG IgA. Okay. 46-year-old man with a history of stricture and Crohn's disease of the small bowel and colon is admitted to the medical floor with high ostomy output and acute kidney injury. He had a right hemicolectomy and unspecified small bowel resection with an ileoclonic anastomosis after complications of stricturing disease 15 years ago. 4 months ago, he developed another stricture that required an additional 60 centimeters of bowel removed and placement of jejunostomy. He reports having 4 to 5 liters of liquid still coming from his ostomy daily in the last 3 months. He has no nausea, vomiting, but admits abdominal pain, 10-pound weight loss, occasional blood streaking the inferior edge of his stomach. Basic metabolic panel, potassium 3.4, BUN 43, creatinine of 2, B12 of 190, which is low, CRP 11, fecal elastase 136, which is low. Fecal fat, 145 grams. Further workup for stool microorganisms, hepatic panelipase, are unremarkable. Patchy areas of erythematous bowel are biopsied during jejunoscopy. The patient is started on rifaximin and prednisone and given an infusion of infliximab. 4 days later, the cramping has improved, but there are no changes in the ostomy output. Which of the following is the most likely cause of high ostomy output? So A, intestinal bacterial overgrowth, B, exocrine pancreatic insufficiency, 3, Crohn's disease, 4, bile acid diarrhea, or E, short bowel syndrome. Okay, so this is a long question stem here. Just going through the key elements: 46 years old, stricture and Crohn's disease, multiple surgeries. He is being admitted with high ostomy output, weight loss. He's got elevated creatinine, B12 is low, fecal elastase is low, fecal fat is elevated. And he started on immunosuppression with improved cramping, but no changes in ostomy output. Okay, you go to the next slide. Okay, so E, short bowel syndrome. Just going through this, there are, there are a couple, actually, can we go back to the question stem first? I'll go through some of the thoughts here. So there are a couple of red herrings in this question stem. One of them is the low fecal elastase of 136. And this is trying to get at the fact that in patients that do have high ostomy output or large amounts of watery diarrhea, you can have dilution of the fecal elastase. So it's not a pancreatic insufficiency, but it's actually just from the amount of diarrhea. The fecal fat being elevated suggests that there is malabsorption here. We can go back to the questions here. So intestinal bacterial overgrowth is very common in patients with short gut, but this patient was already treated with rifaximin without significant improvement. The exocrine pancreatic insufficiency we talked about. Crohn's disease, yes, the patient does have Crohn's disease, but they have immunosuppression without any improvement. And this patient has a jejunostomy. The jejunum is does not absorb water very well. Most water is absorbed in the colon. And so patients that have a short GI tract will have a lot of watery output. Bile acid diarrhea. So bile acid diarrhea can occur when you have a resection of the terminal ileum less than 100 centimeters. And when you have resection of the distal terminal ileum less than 100 centimeters, the bile acids, instead of being absorbed in the enterohepatic nervous system, enterohepatic reabsorption will reach the colon and stimulate the colon to have a secretory diarrhea. This patient is not in continuity, so they don't have any stimulation of irritation of the colon. So that's unlikely to be the answer. And the correct answer is short bowel syndrome, which we talked about. Okay, next question. A 40-year-old Asian female with a history of chronic hepatitis B, currently off therapy, presents with abdominal pain for 3 days. She's been having nausea, vomiting, and some decrease in bowel habits. She has a similar episode approximately 6 months ago when she was found to have acute cholecystitis and was treated with antibiotics and then cholecystectomy. She presents to the emergency room where she's found to be afebrile, tachycardic to 110, with a blood pressure of 100/60. While awaiting lab results, she undergoes abdominal CT scan that demonstrates pneumatosis of the small intestine. The most likely cause of this patient's finding. So PAN for polyarteritis nodosa, chronic mesenteric ischemia, gallstone ileus, Behçet's disease, or rheumatoid vasculitis. Okay, so 40-year-old lady, Asia, chronic hepatitis B, off of therapy, She has had acute cholecystitis recently and is in the emergency room with abdominal pain and pneumatosis on a CT scan. We can go to the questions then. We just wait a little bit for answers to come in. All right. Okay, so we can see the answers. So polyarteritis nodosa, that's correct. The most common cause here.
Yeah.
Dr. Lim Sui, do you want to take this one?
Thank you, David. So yes, polyarteritis nodosa is the correct answer. So this is vasculitis that involves the medium and small vessels, and there's a clear association with hepatitis B as noted in the vignette. And the GI involvement usually affects the small intestine as well as the gallbladder, and you may find pneumatosis. So that fits her history as well. Gallstone ileus, the clinical story doesn't fit with this. That's when there's a biliary enteric fistula where the gallstone is impacting the bowel and causing ileus there. Acute mesenteric ischemia may present like this with acute abdominal pain and pneumatosis, but chronic mesenteric ischemia wouldn't typically present this way. That's more like intestinal angina with pain after eating. Rheumatoid vasculitis wouldn't fit with this necessarily picture given this clinical scenario. It usually happens several years after a diagnosis of rheumatoid arthritis to have GI involvement. And Behçet's is, based on the clinical vignette, not the right answer because that's more likely in young men and also having ulceration involving the oral or genital ulcers. So in this case, polyarteritis nodosa is the best answer.
Okay, great. Let's go to the next question. 34-year-old woman presents with pain in her left foot. 6 months ago, she had cholecystectomy for recurrent biliary colic. Shortly after, she developed diarrhea, which responded well to cholestyramine. She takes it 4 times per day with meals. Over the last month, she has stubbed her toe on the bathroom and hallway furniture multiple times in the night when getting up to go to the bathroom. That sounds terrible. She lives with her boyfriend, who often works late and has put strain on their relationship. Her left foot has multiple areas of scabbing and purpura, especially her big toe, which is also swollen and painful with passive flexion. She has a bruise over her right forehead and dry thickened appearance to conjunctiva on her eye exam. X-ray shows the left foot has a fracture in her left toe. Okay. So we have 5 options. Obtain fat soluble vitamin levels, get a hemoglobin A1C, evaluate for domestic abuse, obtain B12 level, referral to ophthalmology. So let's go back to the questions then. So some of the key things here, 34-year-old woman had a gallbladder removed, then had diarrhea afterwards, was on cholestyramine. She's stubbing her toe in the middle of the night, and she has some skin changes and thickened appearing conjunctiva of her eye exam and a bruise on her right forehead. Okay. So what does she have? Go back to we can go back to the answers. Okay, so obtain fat soluble vitamins, and some of these answers aren't necessarily wrong. Evaluate for domestic abuse, that's an important thing. Although there's no real hints for that on the questions, not in the question stem. Obtain hemoglobin A1C. I think they're trying to get you to think about peripheral neuropathy from diabetes or Charcot's foot, but there's really no evidence of that on the exam or in the question stem. Obtain a B12 level, that wouldn't explain. So B12 can cause peripheral neuropathy and also some difficulty with proprioception. So that's not a bad choice, but they're getting at the difficulty seeing at night, and they're trying to get you to think of the bruising. They're looking to assess whether you understand the relationship between cholestyramine and malabsorption of fat vitamins, fat soluble vitamins. So the fat soluble vitamins that they're looking for is vitamin A is with the weight loss, and vitamin K is with the is for the bleeding. Anyone else have anything they would chime in?
Yeah, I just want to highlight that it's the cholestyramine that puts this patient at risk of fat soluble vitamin deficiencies. And so remember, with A, you think about the eyes, and then with K, you think about bleeding, right? So with vitamin A deficiency, you can get conjunctival xerosis, which is actually notable in this patient's exam. These spots called Bidded spots and night blindness, which explains why she falls and gets injured in the middle of the night. And then the easy bruising and the findings on her foot are mostly related to the vitamin K deficiency. So just recall that vitamin K is needed for gamma carboxylation of clotting factors and your anticoagulant protein, CNS. As many of you may know, cholestyramine is a sequestrant. And so what they contain positively charged indigestible resins that bind bile acids to form an insoluble complex that is excreted into the stool, thus preventing their secremotor actions on the colon. And so it can be helpful in the context of having bile acid diarrhea, especially after a cholecystectomy. But by binding these bile acids, they inhibit fat emulsification and micelle formation, hence fat absorption. And then that puts you at risk of fat soluble vitamin deficiencies.
Okay, great. So we'll go to the next question. 23-year-old woman from Middle East presents to your office to establish care for celiac disease. Upon reviewing her records, you see that she has TTG IgA testing with the normal IgA levels and subsequent duodenal biopsies confirming the diagnosis. Since her diagnosis 2 years ago, the patient reports maintaining a strict gluten-free diet. Subsequent testing after starting this diet showed a normal TTG IgA level. For the past 3 months, she has had increasing bloating and loose stools. You repeat your TTG IgA and find that it is still elevated. The most likely cause for the patient's increased TTG IgA level is A, small intestinal bacterial overgrowth, B, small bowel lymphoma, C, refractory celiac disease, or D, inadvertent gluten exposure. We go back to the question here. 23-year-old female from the Middle East is presented to establish care for celiac. So you confirmed the diagnosis was correct with a normal IgA levels. Since her diagnosis, she says she's been on a strict gluten-free diet, but she has bloating, loose stools, and TTG IgA is still positive. We can go to the answers. Okay, so we can open this one up to the panel here.
Yeah, the majority of our poll got it correct. It's inadvertent gluten exposure. That is the most common cause for increase in the TTG IgA, especially in someone who previously responded to celiac disease with gluten-free diets. So C is less likely, as well as B less likely. So small bowel lymphoma is a known complication, but really unlikely at this time. So we would first have them revisit with the dietitian and make sure they're strictly gluten-free.
Great. Okay, I think we have a question from the last, about the last prompt. Let's see here. For patients on cholestyramine, do you routinely test for ADEK? Dr. Sonu, do you want to answer that?
I do for my long-term patients. So if they're on it basically indefinitely, I'll check them once a year.
Okay, great. And I think another question, how do you monitor / manage patients on cholestyramine?
Yeah, so I monitor annually, and if there's any deficiencies, then I'll replete. Yeah.
Okay, great. Any other questions? I think we can move on here. All right. 20-year-old man presents to the emergency room with dark stools for 2 days. He reports he has been having ongoing abdominal discomfort intermittently for the past month, but never noticed a change in color of his stools until now. He denies taking any medications. His weight has been stable. Physical exam reveals diffuse ulcerations in his mouth and on his scrotum. His hemoglobin is 9.6 on admission. Upper endoscopy and colonoscopy are normal. Video capsule endoscopy reveals deep cratered ulcerations in the jejunum. The most likely cause of this patient's findings is A, Crohn's disease, B, Behçet's, C, surreptitious NSAID use, D, mast cell disorder, or E, Takayasu aortitis. So 20-year-old guy, dark stools, abdominal pain, hemoglobin is low, a capsule endoscopy has deep cratered ulcerations in the jejunum. Dr. Limsui, do you want to, actually, let's go back to the questions to make sure everyone has a chance to answer. Okay, we'll give it a couple of seconds here. All right, Dr. Limsui, do you want to handle this one?
Thanks, Dr. Goldberg. Yes, I will. So, well, the whole audience got 100% correct on this. It is Behçet's disease. So we have a young man and presenting with this necrotizing systemic vasculitis, which is Behçet's. And the key things I would point out is that when you have oral and genital ulceration, that's something that should flag that together with the inflammatory findings on the bowel and the GI presentation. It can definitely mimic as like Crohn's. So Crohn's is probably the next competing best likely answer. But with the genital ulceration, Behçet's would be the most likely cause. Mast cell disorder, you'll have more diarrhea, abdominal pain, you'll have macular papular rash or cutaneous lesions or findings there, and not so much the oral ulceration. And then Takayasu arteritis is more predominantly in females and less likely in this presentation.
All right, great. Go to the next question. 65-year-old man with no significant past medical history presents with significant diarrhea. He reports that for the past 3 months, he's had 4 to 5 bowel movements daily, characterized as greasy and foul smelling, but not entirely watery. He notices no blood or mucus in the stool. Over the same period, he's had increased swelling in both his ankles. The physician sends a broad workup. C. diff is negative, O&P negative, stool culture negative, stool elastase within normal limits, fecal fat is within normal limits, and stool alpha-1 antitrypsin is elevated. Okay, next slide. Which of the following diagnoses best explain the patient's symptoms? A, amyloidosis of the small intestine, celiac disease, ulcerative colitis, or small bowel dysmotility. So 65-year-old guy, diarrhea, he's got foul smelling diarrhea, it's greasy, the stool alpha-1 antitrypsin is elevated, and he has swelling in both ankles. You can go to the next slide. Oh, okay, so A is correct, amyloidosis. So this patient has a protein wasting enteropathy, and the key finding of that is the positive stool alpha-1 antitrypsin. The alpha-1 antitrypsin is not actually what causes the protein wasting enteropathy, but it's a surrogate. So it's really the albumin that's wasting that causes the anasarca and the swelling in both ankles. But the alpha-1 antitrypsin is what we can test in the stool because the albumin actually gets degraded in the GI tract. So Crohn's disease can sometimes have a protein wasting enteropathy, but not typically ulcerative colitis because that's a colonic inflammation. Small bowel dysmotility does not typically affect absorption unless you have severe bacterial overgrowth. So that would be incorrect. And celiac disease, not typical, although You can have either refractory celiac disease or ulcerative gingivititis that can have a protein wasting enteropathy, but amyloidosis is the right answer here. Okay, the next one. 36-year-old Caucasian female with a past medical history of hypothyroidism presents to gastroenterology office for ongoing bloating. Bloating is associated with altered bowel habits, resulting in 2 to 3 bowel movements daily. Tried histamine 2 antagonist agents and simethicone with limited results. There's a whole bunch of labs here. I'll go through these quickly. So on the CBC, it looks like everything is normal. Electrolytes here, sodium, potassium, chloride, a little elevated, but bicarb 24, creatinine is 0.7. The TTG IgA is low. The IgA is 4.5. IgG is normal and IgM is normal. Okay. The next question. Which of the following is the most appropriate test in this patient's workup? EGD with duodenal biopsies, TTG, deaminated gliadin peptide, empiric trial of gluten-free diet, lactulose breath test, or wireless motility capsule. So we go back to the prior question here. And the key things that we're looking at is a patient with hypothyroidism and is having bloating and altered bowel habits. The IgA level is low. For the next question. Okay, give a couple of minutes for people to respond. All right, and what's their answer here? Okay, good. So most people got this one right. And we can open this up to the panel.
Well, she, as the labs noted, has IgA deficiency, and the possibility of having celiac disease is present given her presentation. So the next best step would be, as the majority said, would be deaminated gliadin peptide antibody lab. EGD with biopsies would be appropriate if it was negative and the suspicion still, like in this case, was high. That would be probably the next best answer after that.
We can continue with the next question. 32-year-old with a history of Roux-en-Y gastric bypass 5 months ago presents to the clinic with complaints of rash. 2 weeks ago, she noticed dry, scaly rash over both legs. She tried moisturizing ointments without relief, also has noted frequent dandruff. Appetite has been poor since the surgery, and she's concerned she's losing weight too fast. Examination shows contiguous, dry, scaly rash over anterior legs and cracking and peeling at her fingertips. Labs are significant for copper, 1.2, zinc is 0.62, selenium 102, and albumin 3.1. The triene-tetraene ratio is 0.24. A deficiency in which nutrient most likely explains this patient's symptoms? So A, copper, B, zinc, C, vitamin C, or D, essential fatty acids. Go back to the prior question here. So 32 years old, Roux-en-Y gastric bypass, rash in the legs, dandruff, poor appetite, losing a lot of weight. Labs show copper is in normal range, zinc is a little bit low, selenium is 102, albumin is within normal, and triene-tetraene ratio is elevated. Okay, next question. Next slide. Okay. All right, so most people said zinc here.
All right, so the answer is actually EFAD, essential fatty acids. So this is a tough question. I got it wrong as well when I went through it. And I think they try to trick you here because even though the zinc level is low, it's very borderline low, and you have to correct it for the low albumin. So the albumin is actually not normal in this case. It's actually low. And just as with many micronutrients, you have to correct it. You have to correct. There's a correction factor involved when you're hypoalbuminemic. And so just as a reminder, so essential fatty acid deficiency can be seen secondary to Roux-en-Y gastric bypass surgery. You're actually at risk of both macro and micronutrient deficiencies from this procedure if patients are not eating an adequate diet and taking in enough supplementation. And so EFAD, I mean, the classic presentation is this dry, scaly rash, impaired wound healing and immune dysfunction. But, just hearing those descriptors, you can, there's a lot of other micronutrient deficiencies that are associated with those symptoms as well. But in general, the minimum amount of fat that you need to take in to prevent essential fatty acid deficiency is about 100 grams per week. And so you can make most fats, fatty acids, but remember there's two that you can't endogenously make and you need to take in exogenously. So there's linoleic acid and linolenic acid. And so this is the tricky part. So there's an acid called oleic acid, which is metabolized to triene. And there's reduced production of tetraene. So when you have EFAD, then you're going to actually have an elevated triene to tetraene ratio. And so when you have a ratio that is greater than 0.2, which does apply in this patient's case, then that's diagnostic for EFAD. But just want to mention that, when you have Roux-en-Y gastric bypass anatomy, you are at risk of copper deficiency, you are at risk of zinc deficiency, but technically the patient does have symptoms that can be seen in zinc deficiency, but when you correct for albumin, the hypoalbuminemia, then actually the zinc level is normal. 70% of zinc is bound to albumin. And that's it. Any questions about that one? I know it was a tough one.
Yeah, I also got that question wrong the first time I did it. All right, we'll go to the next one. Okay, 24-year-old female with past medical history of protein C deficiency and Coumadin presents with severe abdominal pain for 6 hours. On presentation, she is afebrile with heart rate of 130, blood pressure of 100/60. On exam, she has diffusely tender abdomen to mild palpation and appears very uncomfortable, squirming in bed. On labs, her white count is normal, INR 1.1, lactate is 4.6. On cross-sectional imaging, she has non-specific changes in the small bowel. The next step in her therapy is A, exploratory laparoscopy, B, IV heparin, C, percutaneous angioplasty, and D, TPN. So we go back to the question. So 24-year-old female, she has protein C deficiency on Coumadin, severe abdominal pain. She's very tachycardic, in severe pain, and lactate is 4.6. She has some non-specific changes on cross-sectional imaging. All right. So we'll go to the answers. We give a second for people to respond. All right. And Dr. Lin Sui, do you want to do this one?
Yes, happy to. So the correct answer is A, exploratory laparoscopy. So this young woman has acute mesenteric ischemia. So this is a medical emergency because she also has peritoneal signs on that. So she has an elevated lactate, basically an acute abdomen with peritoneal signs, and the findings on CT suggestive and consistent with it as well. So that's a surgical emergency, and surgery is the correct answer. IV heparin is not routinely used in acute mesenteric ischemia, especially with acute peritoneal signs. There's been some use of a vasodilator, intravascular papaverine being done, but as far as IV heparin, that is not the routine. So it is a surgical emergency, so it goes to laparoscopy is the correct. And then percutaneous angioplasty, it will be more something considered in chronic mesenteric ischemia that can be used.
Okay, great. Next question. 52-year-old man, status post right hemicolectomy for colon cancer 3 weeks ago. He presents now with progressive abdominal distension. He does not complain of abdominal pain. On physical exam, abdomen is distended and there's a fluid wave and shifting dullness. Diagnostic paracentesis is performed and results are as followed. Serum LDH 356, serum total protein 6, pleural fluid glucose 42, pleural fluid lactate dehydrogenase 242, pleural fluid total protein is 2.9, pleural fluid triglycerides 210, and pleural fluid cholesterol is 90. Okay, so what is the following next best step? A, recommend low-fat diet supplemented with medium-chain triglyceride oil. B, total parenteral nutrition. C, obtain liver ultrasound. And D, placement of gastric feeding tube, start isotonic formula, or E, clear liquid diet. So we have a 52-year-old man had a colon cancer and a right hemicolectomy recently, has new ascites, paracentesis with the following lab values. We can just take a minute to look at these again and interpret them. Okay. All right, we can go to the questions. So give a minute. Do people want to go back and see those numbers again? Should we go back just for a second, just so people can look at this again? Because I know it's a lot of numbers on the screen here. Okay, we can go to the next one. Next slide. I think that's probably enough time. Okay, good. And Dr. Sonu, do you want to do this one?
Sure. So I think what they're trying to get you to identify, we having all the results of the paracentesis, assuming this is ascites fluid communicating with pleural fluid, is the presence of cholesterol and triglycerides in the fluid, which is indicative of cholecystitis. So it says detected in approximately over 6% of patients after colorectal cancer surgery and up to 11 after pancreatic surgery. So it's not that uncommon. But it's diagnosed with a triglyceride level greater than 110, cholesterol level of less than 200, and the presence of chylomicrons in the peritoneal fluid. So initially, this can be managed conservatively with a low-fat diet that is rich in MCT. So MCT, of course, stands for medium-chain triglycerides, and MCT is actually more water soluble and requires less bile to be absorbed. And so it can be more readily absorbed through your enterocytes as opposed to long chain or short chain fatty acids. Long chain triglycerides, which is why you want to not stimulate a lot of chyle production by just being on strictly low fat or MCT containing diet. In more advanced cases, you can make patients strictly NPO and keep them on TPN until the chylous leak resolves.
Okay, great. We go to the next question. 30-year-old woman diagnosed with celiac disease 36 months ago. She has remained compliant with a strict gluten-free diet, including regular visits with a dietitian. She's currently asymptomatic with normalization of TTG IgA antibody and duodenal biopsies. In addition to advising her to remain on a strict gluten-free diet, her management should include which of the following: A, video capsule endoscopy, B, colonoscopy, C, lactulose breath testing, D, pneumococcal vaccination, and E, anti-endomysial antibody. Look at that. Okay, so 30-year-old woman has celiac disease diagnosed 3 years ago. She's currently asymptomatic and has normalized the TTG as well as duodenal biopsies. So what does she still need? Next slide. video capsule endoscopy, colonoscopy, lactose breath test. What do you think? All right, and let's see the answers. Good, so most people said D, which is correct. We can open this one up to the group. Anybody want to comment?
Yeah, so this patient doesn't require any further procedural diagnostic procedures because her celiac disease is well controlled on her gluten-free diet. So there's no need to proceed with a capsule endoscopy, nor a colonoscopy or a lactulose breath test to look for SIBO. But what's interesting is that in the context of having celiac disease due to underlying hyposplenism, you are at risk of pneumococcal pneumonia. So any patient with celiac disease should be getting their pneumococcal vaccination.
Yeah, and I think a couple other things they were trying to get you. The colonoscopy, that would be if she's having ongoing diarrhea, you'd be worried about microscopic colitis. So that was that red herring there. Okay. Next question. 24-year-old man of Turkish descent presents for evaluation of new onset diarrhea in the setting of recurrent oral and genital ulcers. The lesions take anywhere from 1 to 2 weeks to resolve, and he has multiple areas of genital scarring from healed ulcers. He also reports recurrent episodes of redness and pain in the eyes with migratory arthritis of his knees, ankles, and wrists, as well as tender violaceous nodules on the extensor aspects of his lower extremities. Over the past few weeks, he additionally reports 4 to 5 bloody diarrheal bowel movements daily. His labs have iron deficiency anemia along with CRP at 10. Colonoscopy demonstrates terminal ileal and ascending colon ulcerations approximately 0.5 to 1 centimeter with normal intervening mucosa. Pathogy test is positive. He has responded well to an induction regimen of corticosteroids with immediate response. Which of the following agents would you recommend next? A, sulfasalazine, B, azathioprine, C, methotrexate, D, tacrolimus, or E, vedolizumab? All right, so 24-year-old Turkish man has diarrhea, recurrent ulcer, genital ulcers. He has some migratory arthritis and bloody diarrhea, mildly elevated CRP, and he has these focal ulcerations in the terminal ileum and right colon with normal intervening mucosa with a positive pathogy test. He has responded to corticosteroids. All right, Dr. Lims, next slide, please. All right, to do it a minute here. So we're looking for treatment. This is after prednisone response. All right, and let's see the answers. Okay, Dr. Limsui, do you want to address this one?
Sure, thanks, Dr. Goldenberg. Yeah, so remember one of the earlier questions, there was a presentation of Behçet's disease. So this young gentleman has Behçet's. He's also from a country or ethnicity along the ancient Silk Road, has the characteristic oral genital ulcerations, and the appropriate initial treatment is steroids and acute presentation. Unfortunately, there really is a paucity of evidence-based clinical trial data for management of Behçet's. B is the correct answer, which the majority of the audience answered. With the most experience in the limited reports that are available is using azathioprine as a long-term maintenance therapy after induction of remission with prednisone. Methotrexate actually is not necessarily an incorrect answer either, but it's just that azathioprine has more established history or use. Other things have been tried, including sulfasalazine as well, not as effective. Veto, not really used, but anti-TNFs as well as cyclosporin are another alternate for more refractory cases if they don't respond to the steroids initially. But it's a rare and more challenging disease to treat. So probably need more data, and maybe we can get a better answer besides azathioprine if that doesn't work.
Okay, great. And we'll go to our next question. 25-year-old woman presents with 5-year history of watery, non-bloody diarrhea with recurrent bacterial pneumonias. Laboratory studies show iron deficiency anemia with low 25-hydroxyvitamin D. Celiac serologies are negative, and small bowel biopsies reveal a near total villus atrophy, increased intraepithelial lymphocytes, and crypt hyperplasia with absent plasma cells. Which is the most appropriate initial treatment strategy to address the gastrointestinal symptoms? A, gamma globulin, B, infliximab, C, budesonide, D, gluten-free diet, or E, rifaximin. All right, so we have a young woman with 5 years history of watery diarrhea, recurrent bacterial pneumonias, iron deficiency anemia, low vitamin D, normal celiac serologies. She has villus atrophy, intraepithelial lymphocytes, and crypt hyperplasia without plasma cells. So how do you treat this? Next question, next slide. Okay, so look at the answers here. All right, so there's a little bit of a mix. So this patient has CVID, common variable immune deficiency. And it's a little bit tricky because the correct answer is C, by the way. I saw people changing away from C. C is correct. This is a little bit of a tricky question because it's confusing. You have a patient that has increased risk for infections and you're going to give them a steroid. But that's what you need to do because you're looking to get rid of that villus atrophy. Just going back to the question stem, one of the key things that can clue you in on this is that absent plasma cells, and that differentiates this from celiac disease, aside from also the negative celiac serologies, which you still need to do even if you do have absent plasma cells. Back to the answers. So yes, budesonide is the treatment for gastrointestinal side effects of CVID. You can also use oral corticosteroids or infliximab, but that would typically be reserved for steroid refractory or steroid dependent cases. The intravenous immunoglobulin therapies don't typically resolve the GI symptoms. And you might consider rifaximin for patients that have increased risk of bacterial overgrowth. So rifaximin is not incorrect in this situation, but you would still want to treat the underlying CVID first. And gluten-free diet, they don't have celiac disease. Okay. Just open up the panel here. Dr. Sonu, did you have something to comment on?
Oh, I just was typing it in the chat box. This is not regards to this question. This was in regards to an earlier question about the patient that had IgA deficiency and where you're screening them for celiac disease. I believe that there was a typo where the answer was TTG, deaminated gliadin peptide, but it should be IgG, deaminated gliadin peptide, because in patients with IgA deficiency, they obviously can't mount an IgA response, so they're going to have a normal IgA, TTG, and deaminated gliadin peptide. So the next step would be to order an IgG deaminated gliadin peptide, and then if that's positive, then you would go forward with an upper endoscopy with duodenal biopsies.
Great, thank you very much. And with that, I think that concludes our questions. Does anybody have questions about our questions?
Great. Dr. Goldenberg, thank you so much. Great job moderating. Appreciate the panel's input. So, so this concludes it, our day 3 of the 2021 GI Board Review. Thank you again to our moderators, our panelists, our attendees. I also want to give a shout out to Sonia Vittori and Robert Schramm, who behind the scenes have been sort of keeping this as seamless as possible, and really appreciate their help with this, as well as my colleague, Dr. Deepti Jorman-Raju, my co-director for this, and really appreciate her help. On the screen here, you'll see ways to claim CME and MOC points. Mr. Torrey has also placed that information for you in the chat function. I would encourage you to remember that in addition to the live session today, which is taped, we do have the recorded videos as well, with the faculty have put in a lot of work and effort in those. So I would definitely encourage you to go to those and reinforce some of the important topical discussions that were had during these the live question and A sessions. And I think with that, unless anyone has anything else, we will can go to our final slide and end it there. Thank you very much.
Thank you so much, Dr. Kirshen.
Thanks, Dr. Limsu, for joining.
Thank you. Take care. Bye.
So.